Here.
Alex Ramos.
Here.
Carla Wusek. She had to go home early. Chrissy Reeves.
Here.
David Smith.
Craig Ryan. Can you hear me now? Kathy Rogers. And Lori Vinson.
Here.
I just want to remind everybody we do have an attendance requirement for the committee. So if you're not going to be here, you need to make sure you touch base with us in advance. So we're going to go through the trauma systems update. Colin, Jane, y'all have...
Jane is out there. Let me grab her.
We'll just move forward. The one thing that has come up in several of the meetings, not this GTAC meeting, but the meeting before that, was the state trauma system PI plan. I just want to remind everybody that that plan was approved in August of 2011 with the implementation date of January 2014. In addition to the plan, there are PI tools that were created for the RACs and for the EMS agencies and for the trauma centers. The goal was to ask each of the RACs to look at that and begin to develop systems to start tracking that data, and that would become our benchmark comparison or the dashboards for the regions. And so again, if you have questions, all of those documents should be posted. I have some copies with me today if there's anybody in the audience that would like additional copies. Any questions on that? Any questions from the committee members? Wanda, I see you raising your hand.
Yep. Oh, I can go to the DSHS table. Part of our question was actually how do we implement that? It has a lot of information about data that we could, should, might, oughta collect. And once we begin doing that, how do we actually put that in place so that we are using it in a meaningful way to make appropriate adjustments to our system? And so we were very interested in how other RACs around the state were doing that. We probably do gather bits and pieces of that information now, and we use it in small ways, but I'm not sure that we're using it to the full impact that is your vision. So
several people have called me and asked if the February meeting, if there could be like a little workshop to teach or guide people through that. So do you think that would be helpful? Yes? Okay, so let's plan on that. I'll look at a time. It'll probably be an afternoon, evening time. Let me get a show of hands from the different RACs. How many of you are representing a different RAC in the room? Raise your hands. Keep your hands up if you think that will be beneficial. Okay. So the trauma registry work group is continuing to meet. There was a very productive meeting that occurred in early November. And so in the packets for the committee members, you will see the minutes from that particular activity, as well as one of the things that came out of it was a desire for each RAC to establish a trauma system, a trauma registry champion for the hospitals and a trauma registry champion for EMS. And so the goal is for the state and for those champions to work very closely together to build skills and how to manage and how to work with the registry. And so from the Trauma Center RAC registry champions, these were the list of criteria that the group felt like, or the work group felt would be appropriate. And so just reading through them, obviously good standing in the RAC, that this individual would have to be supported by the RAC, and that was critical to understand because there would be trips to Austin for training and for activities. They had to have strong computer skills. They had to have the support of their facility. They had to be willing to share their knowledge, their skills, and their expertise with other members of the RAC. They had to have a working knowledge of Maven. They had to have a strong understanding of how to import and export data from the registries, expertise in registry data entry. They had to be hospital champions and trauma registries. In addition to that, they had to have the courses for AAAM. It was recommended they be a certified trauma registrar, that they have attended the TTAF data management course. They needed to be willing to actively share information with the RAC leaders, members, and stakeholders. In addition, they had to have a strong understanding of the National Trauma Data Bank Data Dictionary and data elements. They had to be a hospital, understanding all hospital levels, data reporting, data extraction, data entry, and report writing, a strong understanding of data validation, and a strong understanding of regional data management. Have a minimum of 3 to 5 years of experience with data management, attend 80% of the meetings, have strong stakeholder communication, attend training programs that they would become train the trainer and go back to their RAC and become the trainer, and serve as a liaison between the RAC and the state registry. And they have the skills and the ability to lead the group at the regional level. Any questions on that? This is the hospital person. Any comments from the committee?
So what about some of the smaller RACs where somebody with all these requirements may not be available to provide that kind of support?
Then the other RACs could assist them with that. The goal is to have a liaison and contact in every region to answer questions. And if that means someone has to travel from another region, then obviously we would like to support that. So this is the EMS registry champion criteria. And Brian Percillo was instrumental in coming up with these recommendations. So again, strong understanding of data collection, data import, direct data reporting. They had to have the support of the RAC, strong computer skills. They had to have their agency support. They had to be willing to share knowledge, skills, expertise with the stakeholders. Strong understanding of the paper or the electronic patient care record and the tracking systems. They had to attend the TTAF data management course. Understand coding, scoring, and a good understanding and standing in the RAC. Ability to train and lead the group at the regional level. Strong understanding of state and NMSIS data points. Expertise with EMS levels of data collection. Understanding of regional data collection and ability to communicate and educate the stakeholders. Have 2 to 3 years of data management experience and understanding. An understanding of data submission in the electronic system for billing companies to send the data, and the third-party payers. Attend and participate the meetings, and again, they serve as liaison between the RAC and the EMS agencies and the state registry. And so one of the major issues that came out of that last work group was it was kind of an aha moment that in most of the hospitals, data is abstracted from the medical record, so it's already a document that someone's already documented on. In the EMS world, that patient care record is what is sent into the registry. And so as they're typing it, in whatever form they're typing it, that typically becomes their registry entry. And so there was a lot of questions about, one person would not be able to do both of these roles. So it was clearly identified there must be an EMS leader and there has to be a hospital leader to be able to move forward. So I would just ask those people that were in the work group if they have any comments, anything they would like to add or clarify. Mary, I know you were there. Jane?
It's really a very good idea, because what it's going to do is this is a huge bite to take. As we keep looking at this registry, it's gigantic. This will help feed into just some of the questions that Wanda asked about how do we put these dashboards together. These are the people that are going to be really very solidly involved in that. You know, there's a lot of information. I can speak for RACQ, and us just now getting our registry going. Having somebody that can take the lead on this regionally and work with some of our other partners would be huge. And then once we can get our data organized, we can start working about validation. It's just, I think it's just a really, really good idea, and I think it would be so beneficial to all of our RACs to participate in this.
I know the Trauma Systems Committee meets this time before the RAC Chairs Committee, so we are going to meet with the RAC Chairs and go over this and obviously get their input and feedback. This is the recommendation from the Trauma System Work Group. Jane, you have any comments?
I just want to second really what Mary said. This is the eating the registry one piece at a time, chunk by chunk, to get people to be able to have compliance. It's a lot simpler or a lot easier to pick up the phone or call someone that you know or that you have interaction with on a monthly or daily basis than it is to always go to the state registry to try to get some of those answers. They can't possibly do it all. There's too many users out there for us not to go in a direction where we have a more manageable group, small groups that can work together. And there's lots of people out there that are interested in using the data and interested in using this registry and trying to find out how to make it work better.
Ms. Kelly Stowell, you were in the group. You have any comments? Anybody else? I'm like, who's calling me?
Oh, you want to join us? You're going to put one on either side of you?
Yes, I am.
Okay.
With bunches. So, Jory, for our particular region, I know there's some other regions. This person may need to be, this EMS person particularly may need to be a coordinated effort amongst multiple regions. For example, a majority of our RAC region has EMS services where their home is in another RAC region and all of the trauma registry data entry is done at the home location. So we have East Texas, it's done in Tyler, we have CareFlight, it's done in Dallas. So for our region, that leaves me with like 2 or 3 volunteer services. So I wouldn't have this person.
Right.
And I don't imagine we're the only RAC that's in a similar situation as that. And I don't want that to think that, you know, I'm not sure how to get, they wouldn't represent our RAC necessarily, but they would be an EMS person.
Well, Brian made us aware of that in the work group, and so the recommendation is that even though that person may not be a member of your RAC, but because they're EMS agencies in your RAC, they would still be accountable to come to your RAC to make sure that everybody in your RAC got that information and share that information. So again, as Lori pointed out, there may be people that are, you know, serving 2 or 3 different RACs, or, you know, we may look at it a little bit different, but the goal is to identify a person that Christine can call on when there's a question with the EMS registry.
And I would just add that particularly to this one, and it may work on the hospital one as well, but that, you know, this person has to be willing to go to RACs outside of their home RAC to do the same thing because their service is in other RAC regions.
That's a good point. We'll do that. Anybody else? I don't see Tammy here to ask her any questions. Janie, other comments about the work group activities?
I just think this work group has been a great eye-opener. I mean, just the discussions at this work group. I think EMS had a better understanding of what hospitals were looking for from EMS. Just the discussion in the room, I think, has led to a greater understanding between the 2 groups of what the needs are, and there's been a real willingness and a real desire to work together to make it successful. So I think it's been very positive.
One of the major things that came out of this, not this last work group, but the work group before that, was the interest in sharing information between hospitals and EMS. And so this particular issue was addressed, these champions. In addition to that, there was significant discussion of how to open the door so that EMS can look at hospital data in the state registry and vice versa. And so that is still going to be our number one focus. EMS providers are saying we want to know about the outcomes of the patients. We want to know what happened to the patients we brought into you. And then, of course, the hospitals are constantly looking for that EMS record, patient care record. So there is a strong support to do that within the work group and to open those doors. And so Brian Portillo was asked to be the person who talked to all of the EMS agents, the EMS committee and the EMS medical directors and the Air Medical Committee, and to begin to look at the data elements that they wanted. And so what we essentially did is printed out a registry profile. In addition to that, we asked them to look at what data elements actually go into the registry to see which ones they want, which ones they would like to see. Any comments from anybody else? Well, I think that we're going to ask the RAC chairs for guidance tomorrow. So again, you know, we like to look at data, and so these are some of the things that we found from looking at the data. So the first thing is, again, we've looked at this data before. So for 2011, there were 117,122 trauma incidents in the state of Texas, and you can see them broken down by the level 1s, 2s, 3s, and 4s, and then those non-designated are those facilities that are seeking designation. So for those of you who can't see in the audience, there's about 3,800 that were in the level 1 trauma centers, 13,000 that were in the level 2, 30,000 that were in the level 3s, 24,000 in the level 4s, and so that gives you a breakdown of those patients. And then you can see the total, and you can see the age breakdown of the patients. And this is, again, the Texas trauma incident by age, so you can see that older population is increasing. This just compares it. The top is the Texas annual report. This is the 2011 data, and then it compares it to the 2012 National Trauma Data Bank, which is also 2011 data. And you can see the graphs look very similar. Again, this is one of the things that Dinah and I took to the legislators. This is our mortality incidence. And if you notice in the state of Texas, our mortality rate is 2.78%. And through the National Trauma Data Bank, it's 3.80%. So you can see we are significantly lower in the Texas trauma system. And this is Texas case fatality by age. So you can see, obviously, in that older population, they don't tolerate injuries as well. And this is a Texas trauma incident by age and trauma center level. So the red is the level 1, the green is the level 2 trauma centers. The blue, almost a purple look, is the level 3. And then the sky blue is the level 4 facilities, and that orange, again, is the non-designated. Those are hospitals who are seeking the designation level. And this is a very complicated looking slide. So Dr. Stewart and Garrett and I and Courtney were interested in looking at shock outcomes in the trauma registry. So this is one of the reports we're going to be trying to develop in the next 6 months. But this shows you a little bit about that. In 2011, the trauma registry admissions compared to the mean age. And again, this looks at the shock patients. And it shows you that those patients that have a blood pressure less than 90, and then we also broke that down into those that are over the 16 that are in shock. And so this is the percent of trauma patients greater than 65. In the same grouping, again, you can see those patients that are in shock. And then the ICU length of stay, you can see for the mean ICU, for the patients in shock that are hypotensive greater than age 16, it's a 7.6 average length of stay. This is from all of the patients who are in the registry. And then for the red bar, it's 7.45, and those are the patients, all shock patients. And the median ICU length of stay, again, for all patients is 2 days, And for those patients that are hypotensive with a pressure less than 90, it's 2. And then if you exclude those and only go about those that are older than 16, you'll see it's 4. And so this looks at the mean hospital length of stay by report. This is the mean length of stay by age group, by groupings. And again, this is all patients are in the blue, it's 4.66. Shock patients with a blood pressure less than 90, and then that's the red bar, it's 5.98. And then shock with a pressure of less than 90, greater than 16, and it's 7.17. So again, we're comparing this to the National Trauma Data Bank and looking at our outcomes. And this is the case fatality. Again, the blue bar is all patients, which is 0.027. And then those patients that arrive that are with a pressure less than 90, it's the red bar, it's 0.29. And then the green bar shows those patients that arrive with a pressure less than 90, they're older than 16, and it's 0.36. And this is a complicated looking slide too. This essentially shows the patients by each rack. And this is specifically looking at the data for the length of stay. And then this is one of the critical things that we were looking at is the EMS trauma registry. This is 2011 data with hospital admission. And that there's information that's not known or not reported through the injury severity scores. And so again, this is one of the critical issues, and we looked at this through the work group, and this is one of the driving reasons to try to get these champions on board so we can drill down a little bit deeper and find out what is missing in the data and begin to correct that. Because again, if you look at these numbers, if there's missing data, then that means that the data is really not valid. Any questions on the data? Now, all of the PowerPoints, if you guys remember, we will put them on the DISH website, and we also put them on TTAF's website. So if you want to look at this in more detail, give us about 2 weeks, and you should find all of those PowerPoints on the actual website. Any questions on the data from the committee? It's straight out of the registry. So from our work groups that we've established, the trauma systems, the trauma medical directors work group, Brian Eastridge was not able to be here today, and again, their challenge is to look at evidence-based practice guidelines. They're looking at the activation guidelines, the geriatric guidelines. We also asked them to look at some activity regarding HMO trauma transfer guidelines that were happening out in the southern region of Texas. We also asked them to look at the role of telemedicine for trauma and guidelines for the trauma medical director job description, and they are actively doing that. They have had 2 meetings. There are a group of people that he has asked to work with him, and there's 2 representatives, or the target is 2 representatives from level 1s, level 2s, level 3s, level 4s. In addition to that, he's also looking for 2 orthopedic surgeons and 2 neurosurgeons to be involved in that, and 2 individuals from the pediatric trauma facilities. So that most of those people have been contacted, and they are actually meeting. This is the TQIP geriatrics, and this is one of the things that Brian's group is looking at. We have learned that we can post this and share it with everybody, so it should be posted. If it's not, we can check with Brenda and make sure it's posted on TTAF as well as posted at the DISH website. So these are some of the things we talked about last month that are being evaluated by Dr. Eastridge's group. This is geriatric trauma care, the field triage criteria. And then in addition to that, the best practice guidelines. So I'm not really going to spend a lot of time on it because his group is looking at that, and we'll have to bring those recommendations back. Any questions from the group, from the committee on this? So the next work group is a mid-level work group. So this is something that will be an action item. The committee will have to approve this. I've asked Kelly to look into this, and with your blessing. So Kelly Stowell, and so the goal is, if you really read about the workforce, we're going to find ourselves with a shortage of physicians. So the goal is to look at guidelines for the non-physician providers' utilization in the trauma programs across Texas, to look at their skills, credentialing, competencies, and then job description guidelines. And then at the last meeting, we did approve for the RAC System Development Work Group. This was, I think, 2 meetings ago. Wanda came up to the mic and asked for this work group. And we did talk about this at the last committee. We did move forward with it. And with this group, it's to define the status of the system development, foster sharing best practices between the RACs, and then to provide opportunities for standardized review. So, Wanda, is there anything that you want to comment on this? Okay. And then this is one of the things I know Jane has some information on. We did have the ACS Trauma Systems consultation, I guess, in May of 2011, 2010. So you want to comment on this?
Well, we've been working with the ACS to try to hammer out how we can proceed with our regional assessments of our 22 regions, and that still has not been finalized. I'm working on budget right now with ACS, and as soon as we have more, then we'll let you know. We'll have the American College of Surgeons will come into probably 6 regions and do the assessment and the consultation piece. Then we are partnering with schools of public health to put together internships where we will go into other regions and with the schools of public health do the assessment. ACS will come back in and use the assessment done, and it's using the standard BIS tool with the HRSA model. And using that we've done with the schools of public health, then the ACS will come back in and do the consultation piece for that region. All of this timeline is over 24 months, so we're looking 2 years, all of it to be completed by August of 2015. There are still lots of fluctuations right now as far as trying to get things solidified with the American College of Surgeons, also with selecting interns with the schools of public health. So there's still a lot of things to really be determined, and there's some unknowns right now. I guess I can go ahead and say this. Q has graciously agreed to be the first rack up to have the full ACS assessment and consultation, followed by E. Our plan is to have the interns on board and that they will actually attend the assessments and consultations at Q and E before they begin their rollout of going into the regions. We don't have a timeline yet, or at least not a solidified timeline for E and Q until we're looking at probably sometime in February, but the dates have not exactly been nailed down. Questions? Okay.
You guys are awfully quiet today. Anybody in the audience want to make any comments or ask questions about that?
I have one question just to roll back. Who's chairing the mid-level work group?
Yes.
Kelly, stand up. Kelly Stowell. The next item on the agenda is follow-up from the alcohol-related injuries that we had a nice presentation with Carla and Christy and Kathy at the last meeting. So, Christy?
So our recommendation was to go ahead and post those results and develop education based off of those findings on alcohol testing and the reasons why you should do it, go along with that. And that, there was a lot of issues that we felt weren't true, like the insurance denying the payment. So all of that education should be rolled into that, all of the reasons why the providers weren't doing the testing.
Any questions or comments from the audience?
I thought we had decided to resurvey and get more information.
We were going to, and there was concern from TTAF that there would be duplicate hospitals that would be resubmitting their data, and then that could skew those results if we have some facilities that were answering the survey twice. So.
I will tell you that we did a sampling of this in the Trauma Service Area E, and during the holidays, there's a 42% increase in alcohol-related injuries. And so I mean, we could do a lot with that if we had all the information across the state. So, any other questions, comments? It's not posted.
That was our recommendation.
Their survey report should be posted on TTAF and the DISH website from their original survey. So the stakeholder reports, obviously Dr. Stewart is not here. He does our presentation or represents us at the GTAC Council in addition to Region 6 COT. I'm not sure that everybody in the audience knows this, and I guess it's public knowledge now, but Dr. Stewart is now the chair of the ACS COT at the national level as well. So the next item is TTCF. Lisa, do you want to talk about, or one of you want to talk about TTCF? I don't see Courtney in the room. Courtney, you want to talk about TTAF? Or Marvin, is he in the room? Or TTCF?
So TTCF met on Friday. We had a presentation on a speaker about House Bill 1191, which is some of the changes that emergency departments are facing with sexual assault victims that come into their emergency department. The committees met, each are moving forward. Our strategic plan is set for January 10th in Waco at Hillcrest Regional Medical Center, Hillcrest Baptist Medical Center there in Waco. The new officers were sworn into office, and the current officers are off-stepping at the end of the year. So,
thank you. The level 4 facilities, Christy, are you going to do that?
I don't have any.
No. The level 3s? No comment. Level 2s, Ms. Boyette?
I don't have a report.
The level 1s? One of the biggest issues from the level 1s is the funding and the change in the health care reform. Lisa, you want to give an update on the TTAF Trauma Division?
Sure.
The Trauma Division has been working on several different projects. One is trauma productivity guideline, and we have a work group that we've put together to kind of look at the amount of time and FTEs it takes to run a successful trauma program in each level of the trauma program. There's not a lot of current literature about that. There hasn't been a lot of studies about that outside the very large trauma centers. There's some work that's been done. And so we feel like this is a worthwhile goal to look at this and try to identify maybe a recommendation, a tool, a white paper. We think this is going to be a project that's going to take some time. So we're not going to have a work product ready, in 3 months to put out there, but we're going to continue to work on that. The second thing we're doing is a geriatric trauma work group, and what we are doing is identifying best practices that we can post on the TTAF website so that others can have those available, and also identifying geriatric trauma educational opportunities. We have a group that's being led by Rosie Bollenbacher on clinical practice guidelines on burns, and it's essentially practice guidelines for non-burn centers. Burn centers, of course, have that nailed. It's the non-burn centers that sometimes struggle with how to appropriately manage fluids and transport and transfer patients. And so they're working together. She's got representation from most, if not all, of the burn centers, and also she's working on getting some EMS representation to move forward with that. There is a group, and this is actually kind of a joint effort. The data management course is also coming out of the Education Committee, but the data management course will be on January 30th at the Children's Hospital of San Antonio, and we're happy to have that. It looks like a great lineup. You can go on the TTAF website to get the brochure and the lineup for that. I think that's it.
Thank you, Ms. Lisa. I don't see anybody from TCEP here. Is there anybody want to give an update from the emergency physician's perspective? So I see Ms. Sally. Sally, you have something from ENA?
Thanks, Tori. Just a quick update on TNCC. The new TNCC manual will go to print in the next week or so. The rollout is planned for January through April. The drop dead date for the last 6th edition TNCC course will be April 30th. So the plan is to update instructors very much like ENPC was done. There'll be several modules online. Everybody will get their new book. And then we'll do the test online. There was a pilot course conducted in Nashville at the annual conference. Went very well. There was a lot of things picked up by experienced and not so experienced instructors that led to some changes that we think are going to be very good changes. They tested about 150 test questions and had a really nice bell curve on those test questions. So looking forward to a successful rollout for 7th edition TNCC.
Sally, what's the increased cost now?
The cost for the manual at this point was originally said to be $75. That's not the case. It's going to be $68, and I think that's pretty firm. The price of the manual's not gone up in 9 years, and the plan is to have a better quality paper than has been put out in other manuals in the past, and to have some color photographs and stuff in it. So that's the reason for the cost increase, and just for, it costs more to print things these days. So, any other questions? Okay, thanks.
Thank you. Lori, I skipped you with pediatric trauma centers. Do you want to give an update and also talk about that child abuse issue?
So one of the things that the pediatric centers talk about pretty often is the inability to truly get accurate child abuse data. When you look at the National Trauma Data Bank and you look at the percentages, it's really low, and those of us at children's hospitals know that that's pretty much our numbers. And when you look at the state level here for us in Texas, it's pretty much the same story. So recently, several of us we just went to TQIP, which is the Trauma Quality Improvement Program through the ACS and the National Trauma Data Bank. And one of the questions that is available through TQIP that maybe we could have available if people aren't comfortable using the E code of yes, this is abuse. And you don't have to know who the perpetrator is. There's an E code where it lists it's all these people, but there's also an E code that's generic. That is, we don't know who the abuser is, but we know somebody did something to this child. That's always a choice. But if you're not comfortable with that choice, there's always there's the question of, was law enforcement or Child Protective Services called because suspected abuse? And if that answer was yes, and we had that data available to us, we could query based on that information. So we need to do something. I think we should start here in Texas of having a better way to query this information and truly getting a more accurate picture of the true volume and impact that child abuse truly has here in our state, which currently here or nationally we don't really have accurate information. I don't know if anybody has thoughts on that, but it's pretty important to all of us at the pediatric centers. And I think we would want to take the same thing and transfer it over to geriatric and domestic violence as well. Thoughts? Anybody? Comment?
Yeah, this is hugely important. When we started to look at our data in Q, we scratched our heads about the very same thing, and things are being put in there as assault. which I guess you could temporarily say, okay, if a 4-year-old was assaulted, it wasn't probably by another 4-year-old. But it comes in the form of falls, it comes in the form of we don't know. And by attaching that E-code to it, you're not assigning any blame. You're not, we're not the ones responsible for investigating this. Nobody's ever going to go into our registry to find out what we put in there. They don't care. But we need to be able to find a way with this generic E-code, which means that somebody hurt the child. It's not saying who. It just attaches that E-code on there so that we can then go back into the system and say, did you suspect that abuse occurred? And that's where everybody kind of stumbles a little bit. So really suspicion is the only thing that we need, the only bar that we need to cross. So it's suspicion, and then Lori's follow-up question to that was, did you call CPS or law enforcement? And that really tells us that your suspicion is very high. So we really need to have a starting point. We're really having a very difficult time teasing this out. I can tell you that in the last 2 weeks, I've had 3 children under the age of 1 that have died in my institution due to child abuse. My institution, I'm one place, Lori, Sally.
So what I would recommend, my recommendation would be, and maybe it's the pediatric centers, I'm not sure, but come together and put together a document of recommendations clearly on how this should go into your registry and options that you have, as well as some education related to it.
Thank you. I guess my question, Lisa, do you know, or maybe Brenda could address this, does the data management course, is that going to talk about this pediatric abuse issue?
I don't know. Do you know, Brenda?
So could we put that as an opportunity moving forward? And then do we not also have a celebration of a level 3 pediatric facility in Texas now?
Driscoll Children's is a level 3.
That's I don't think we've talked about that at this committee yet, have we?
I don't think so.
It was, yeah, they were designated a while back.
Yeah.
So it's our first
Yes.
pediatric freestanding children's hospital. Will be a level 3 trauma center in Texas.
So that is a celebration.
It is a celebration.
Yes. Alex, did you have anything from EMS?
I don't have a report.
Okay. I know Ms. Welch is in the room. I see her. You have something from TTAF you want to provide an update? Okay. So these are some of the things that are opportunities for this committee. So the one thing is the impact of healthcare reform and how it impacts the trauma systems development. There are a lot of questions that I get about the standard dollar amount and that formula. So I don't know, Emily, if you can answer that, or?
Sure. What's the question specifically?
The formulas and the issues regarding the standard dollar amount. I think there's a lot of trauma coordinators that look at, what their reimbursement for 3588 is, and they see it significantly different, and they're not in the queue to get information from their administrators about the standard dollar amount. So there's a lot of questions.
Okay. So just to sort of start from ground zero about how that's all working. Okay. So beginning in FY12, the trauma add-on was an additional condition to receive an increase in the standard dollar amount for Medicaid patients. And what happened was for the 3588 monies, which is the money collected for the driver responsibility program, what we did was basically shunted $26 million over to HHSC, who administers the SDA trauma add-on funding, and they were able to bring down more federal dollars for that. And Jane, I can report on what it will be for FY14, but Jane, do you remember what it actually amounted to as a total amount for FY12 and 13?
Well, we brought down an additional $34 million. So it basically increased the amount that's going to be pushed out to trauma facilities by $34 million.
And then for For FY14, we're actually going to shunt 33 million. So it's an increase from 26 million to 33 million, which means the total amount to the SDA trauma add-on recipients will be between 62 and 63 million in total. So that total amount is increased to those eligible.
Mm-hmm.
The allotment from the 3588 pot remains the same, which is to hospitals is a total of 54.7 million this year.
So is there any way the hospitals can go into a website and see what the standard dollar amount for their hospital actually is? I think that's the big question, because they see this gap from what they used to get to what they're currently getting, and they don't have the answers to that.
Right. I'm not sure if HHSC posts that information, but I believe they can get that directly from HHSC. Laura Skaggs is the contact at HHSC that can provide whatever information that is specific to each facility.
Okay.
Right. Jane's adding that they could get it from their CFO as well.
I think that's the opportunity there.
Okay.
Okay, the next item on the agenda is an opportunity for Texas TQIP. Again, several of us were at the National TQIP meeting, and there are several states that have a TQIP project. There's the Michigan, Georgia, Arkansas, and Florida, I know, have their own state initiatives with TQIP. And so I met with the TQIP leaders and Matt Davis from Scott and White, and we asked the question, how could we start a Texas TQIP? So obviously there's a lot of questions that have to be raised. The first obviously is funding, but there's several ways we could go about this, and that is to all of those people who participate at the TQIP that are from Texas could meet and share their data. The other option is to get reports from all of the Texas centers that participate in TQIP, and instead of benchmarking against other trauma centers in Texas, you benchmark against the other states. So there's several ways to look at that, and so one of the opportunities for this committee is to ask Matt Davis to work with the TQIP group and actually define options for Texas and then bring it back to this committee. So again, that's going to be one of the action items to present to you all. Any questions on that from anybody? I know, Lori, you were there. Mary, you were there. I think, Terry, you were there, weren't you? But I know Matt was. So I know the people from JPS was there. From El Paso.
Memorial Herman.
Memorial was there. So there's a group that are there. So I asked for a list of all of the hospitals that were represented, and clearly they're level 1s and level 2s because level 3s haven't been given the opportunity to participate yet. But I think that if you want to look at benchmarking data for the state, it would be nice to have that. And then the other opportunity that we learned from being in the TQIP meeting is an opportunity for the trauma registrars to have a work group off of this committee. And so again, the question that I have is, it's a great opportunity to bring them on board. I know that they have an opportunity through the Texas Trauma Coordinators Forum, but they also were hoping to get a voice to come through this committee. So those are the opportunities that I've been made aware of. Any other opportunities from the committee members? Anything you want to list on this topic of opportunities moving forward?
This may go under healthcare reform, I'm not really sure, but the Dispro Share funds, if they were to go away, a lot of facilities, when they look at, cost-benefit ratio of being a trauma center, that Dispro Share monies that they get really helps the bottom line, and if that goes away, I'm just afraid of what that's going to do to our system.
Stay tuned. Okay. Anybody else? Anybody in the audience think that have ideas or recommendations to add to this opportunities list? Well, to move forward, this is some of the information that was pulled out of the Patient Protection and Affordable Care Act. And this does look specifically at the disproportionate funding. I know Lori asked this question before. So this is straight out of the bill. And it says that states' disproportionate share hospital or the DISH allotments will be reduced by 50% once the state's uninsured rate decreases by 45%. So I don't think Texas is there yet, right, Jane? Disproportionate funding rates continue to decrease as uninsured citizens' percent decrease. So I think, you know, straight out of the bill, it says that the disproportionate issue is directly tied to individuals signing up for the health care. So there's a direct proportion to the increased number of people that sign up, then DISH will decrease. And so this is something it would be nice to be able to monitor this, but I don't know who, Jane, would that be your group that would have the facts on the percentage of people signing up in Texas? How would we know this? So.
Probably the national webpage, I would say.
And that doesn't work?
You can count them on one hand.
I guess my question is, should this committee, should the state, should there be some place that we monitor this? Because I think Lori's right. This would have a significant impact to the Texas trauma system if the DISH money went away completely.
Well, you know, that's the way it's going, is that it's going to be decreased and probably eventually would be done away with. But that's also, you have to remember what we just talked about on the standard dollar amount, the trauma add-on. So it's changing how it's being delivered. From this perspective, at least, we took that step before we started diminishing or decreasing the disproportionate share funding. Actually, standard dollar amount was in place, and those funds are being disseminated out to trauma facilities. Next year, we will be shifting more of the 3588 monies over to HHSC to pull down more federal dollars, and it's a 40-60 match. So we have $40, they match it with $60. So it's, from where I sit, it's a good thing for the funding. So I think you're going to see the disproportionate share funding go down, and it may completely go away, but there'll be other funding sources that will come in. It may not offset it completely, I don't know.
Well, and I think that's going to be the key as Dispro goes away and other sources come up. A lot of facilities became trauma centers to get whatever that funding is, and so the statute or whatever is written that is that requirement is going to have to be adjusted to say, you know, whatever the other dollars, wherever they're coming from. Right now it just says Dispro, the DIS money, and it's just going to have to, the language is going to have to be adjusted.
Yes.
Brenda, we have absolutely no control over that. That is administered through Medicaid. And so as far as, frankly, we had very little input into that. Now, the one thing that is in that rule is that if the level 4, level 3, or level 2 is in a system with a level 1, they actually get funded off of the higher designated facility. So the standard dollar amount, the trauma add-on to the standard dollar amount is actually higher. So you may see some facilities try to capitalize on that. And facilities that weren't a level 4 that were in a system, now they want to become a level 4 because they can then get that add-on to their SDA because they have a facility within their system that is running at a level 2 or 1. Correct. That's the way the rule, that's the way HHSC wrote that Medicaid rule for the trauma add-on. Okay.
Jane, when you say system, do you mean under the same license number, or do you mean system of hospitals?
I knew somebody's going to ask me that.
Well, because that is a big distinction.
It does. I'm not sure if it's the provider number, the Texas, the TPI number, if they're operating on the same TPI number, which for Medicaid purposes, that would make more sense than if they're operating on the same license.
Right, so it's a TPI
Right.
number, but that still makes a difference in when people are thinking through their plans.
Right.
Is it TPI? Okay. Okay.
We're pretty sure, Emily's pretty sure it is TPI, but we'll have to go back and look at the rule and verify that.
Okay.
Additional information that it's straight out of that Healthcare Act or Healthcare Reform, and you can read this. It's the Secretary shall establish 3 programs to award grants. These grants will focus on assisting and defraying substantial uncompensated care costs. Furthermore, the core mission of the trauma centers, and then obviously it's looking at targeting the cost of stabilization and transfer, the trauma education and outreach, coordination with local and regional trauma centers, and FTE expenses, and provide emergency relief to ensure continued and future availability of the trauma center. This is straight out of the rules. I didn't do anything except copy and paste it. And then, again, to move forward, the grants to the states funding to support physician compensation and trauma-related physician specialties where shortage exists, and the priority will be the safety net facilities, physical stability to ensure 24-hour capabilities, reducing trauma center overcrowding due to throughput of the trauma patients, establishing new trauma centers in underserved areas, enhanced collaboration between trauma centers and other hospitals and EMS personnel, capital improvements to enhance access and expedite trauma care, enhance trauma surge capacity at specific trauma centers, ensuring expedient receiving of trauma patients transported by ground or air EMS, and enhance interstate trauma center collaboration. So again, these are straight from the rules. We talked about that already. And then this is the opportunity for the state TQIP. And again, Matt Davis has been a leader in the TQIP at the national level, so he is the one that I asked to look into this and explore this and to utilize participating TQIP hospitals from Texas. And again, the goal is Matt can review different ways, different options, how to compare the data, whether it's comparing hospitals. We can compare regions, but if you look at the hospitals that are participating, it probably would be best to compare our outcomes to the other state outcomes. Any comments from the group on this?
Jory, just since we're on that topic, I've been wanting to tell Lisa, but I haven't had a chance. And you guys can correct me if I'm wrong. At TQIP, there was a challenge that was sent to the Society of Trauma Nurses, along with TQIP, to also work on productivity guidelines.
For the registrars?
For registrars only. I thought it was going to be also for coordinators and all other trauma systems.
I understood it just to be the the trauma registrars, but I may be wrong.
So, I mean, if Lisa and the work group at TTAF already took that initiative, it might be wise just to reach out to Society of Trauma Nurses and TQIP, so we won't be duplicating efforts and just work in conjunction.
Well, they're not started yet, so. And then the other option, talking to Irene Lopez and Garrett and several of the other registrars, they feel like there's a need to really work with the educational level and opportunities for the registrars in the state of Texas. Any questions on that? And then general public. So anybody from the audience have any comments on any of these topics or any new topics? Okay, that would be good.
Is there any timeline for the trauma registry group in the combination with EMS to start actually sharing the data and being able to use the data? And is there like a year from now, 2 years from now, 6 months from now?
Well, part of it was with the registry software had to look at options, and there was also a question of cost for the software. And so we're supposed to get some type of feedback at the February meeting, and then we can answer that from there.
There's a burning desire. I think the timing is perfect for what you're doing. I'm glad to hear the progress. The EMS agencies and the hospitals clearly, at least in our area, want to work together to get that data. And an eye-opener for me in Houston, it might just be a Harold Pilot, but I was never aware that the EMS agencies didn't necessarily know about ISS scoring. And as a result, we hear about the patients being discharged from level 1s with different ISS scores, the lower level patients being brought in by ambulance, by helicopter, and we go, well, why is that happening? Well, the ambulance folks didn't necessarily know when they bring the patient what that ISS score is going to end up being. And so this discussion has gone on for years, and you need to make some sort of statistic that is going to help EMS better understand when to use the level 1 and when not to use the level 1, because it's just as bad to overutilize a level 1 trauma center than it is to underutilize it.
Anybody else from the work group have any comments for Mr. Powell? Anybody else from the audience have any comments? It's your chance. Any open comments from the committee members? Then we'll move to the action items. And so as far as action items, I don't know that we could do anything with a standard dollar amount unless we find somebody to come and provide more details. I think Jane and Emily have done a good job at updating us. Any desire to do anything with the standard dollar amount? No? So the next opportunity is the mid-level work group. We can address these. We have the mid-level work group, and we have the TQIP work group with Matt Davis, and the trauma registry work group. So we can do them individually or as a group.
I move we support those work groups. Is that what you're looking for, George? I move that we support all 3 of those work groups.
There's a motion on the table. The second by Mary. Any other discussion from the committee? Any comments from those in the audience? If not, please say aye if you agree.
Aye.
If you disagree, please say aye. That motion passes. Thank you. And then the other issue is healthcare reform. So again, there's lots of data that's out there. Don't really, you know, is this something that we would like more information on? Or Jane, is there some place at the state we can go look at the impact of the healthcare reform, or we're just going to keep monitoring this? What would you suggest to us?
I'm sure there are probably lots of different areas of different agencies that are monitoring healthcare reform, and HHSC would be the umbrella agency. As far as what they're putting out, you can monitor it on their website. We get informational blasts from time to time about what the impacts could be on the state agencies and to the providers, but honestly, it's not something that we have been tracking in our office.
I guess one question I have when I read this is there an opportunity for any of us to help the state with writing these grants or getting more information about what grants are actually available? Or, I mean, I looked at the actual act itself, but I didn't see anywhere where it said these were the actual grants that you could apply for. Is that just, how does that work? Do you know?
I don't, I'm sorry.
So I think probably the most important thing anybody in the audience can do, and anybody that's on the committee, is if you just do a simple Google of the Patient Protection and Affordable Health Care Act, and then add behind this Title III, Section 305, it will take you straight to all the documentation that discusses the trauma system issues related to this bill or to this act. And if you go above it and below it, you'll find all the information about public health as well as EMS. And so I think it'll put you to sleep if you have insomnia, but it's something I think that all of us need to educate ourselves and get a better understanding. Because when you read it, there's several places that talks about these grants, but I don't know where these grants, how to access them, and what they're actually going to be supportive. And I don't know if there's another document that's supposed to come out and say, okay, this is what we're going to do now that we got the act and we're moving forward with it. So just lots of, it made me have a lot of questions, and I don't know if the other committee members also have those same type of questions. Anybody have any comments?
Is there anybody at the state that could do even just a webinar that fully understands all this, that could, do that for us to just hop on and see if we can learn a little bit more about this? Because I tried to read it too, and
Maybe they could
it's
do a
painful.
presentation, February meeting,
Yeah.
something like that, an update with the latest from HHC or.
Is there anybody could?
I can't hear you, Lori.
I was just making a comment that maybe somebody could, that's knowledgeable on the subject, could come give a PowerPoint presentation during the next trauma systems meeting in February with whatever the latest and greatest is, answer some questions that people may have, and that way gives us a few months to do what you were suggesting a while ago, look up maybe what our questions are, and then, kind of have a question answer.
We can see if we can find somebody. We'll work on that. Okay. Okay, so we're kind of at the end. Anybody else have anything they want to bring up?
I would just propose that based on the pediatric content that we talked about, that the pediatric centers would come together with recommendations for the child abuse entry into the registry and follow up and bring that back to the February meeting.
Thank you. Any items anybody else wants to bring for follow-up in February?
My last comment, I guess, back on the alcohol information. While I understand there was concern that there might be duplication of submission, on the other end of that, I'm concerned that not everybody got an opportunity to submit what they do or don't do, and that the data we have is not representative of what's actually going on.
I know for the state of Texas, our numbers increased from last year with the number of fatalities related to alcohol. So Christy, do you want to take that back to your group?
Yes, I can. I also was wondering if there's information that we can gather from our state registry as far as the alcohol-related injuries and deaths, at least the ones that we're putting in their registry.
At least we're submitting, and that would be a better place, more representative.
I think the problem is that when we looked at that before, if they're not drawing it, they don't put yes or no, so it's just blank. So it turns out to have a data field that doesn't provide a lot of information to us.
Yeah, we follow the NTDB answers, and I'm sure not everyone does that, but.
Yeah. I mean, we answer that in our registry, but, if it's not drawn, of course, then we're not going to have data, but it would be interesting to see at least what data we do have now.
Anybody from the audience have anything they want brought back up in February? We're trying to engage your discussion. All right, I'll take a motion to adjourn. Thank you very much.